Dear Chairman, ladies and gentlemen, good morning. I'd like to take this opportunity to thank you for this truly honorable invitation. So today's lecture is going to be on Lirads, which is a comprehensive system that standardized terminology, technique, interpretation, reporting and data collection for liver imaging. It includes 4 algorithms: the ultrasound surveillance algorithm for HCC surveillance, the contrast-enhanced ultrasonography diagnostic algorithm for HCC diagnosis, the CT and MRI algorithm for diagnosis and staging of HCC, the CT and MRI tumor response assessment, which is an algorithm made in order to evaluate lesions after locoregional therapies. Cherniak in 2018 showed that it improves inter-observer agreement, and last but not least, it integrates imaging findings with management recommendations. For time efficiency, I will devote the talk on the CT and MRI diagnostic algorithm and the tumor response assessment. So this algorithm applies on patients with cirrhosis or chronic HBV infection or current or prior HCC, regardless of lesional size. It includes 5 major criteria: the non-rim arterial phase hyperenhancement, the non-peripheral washout, enhancing capsule, the size and threshold growth. Apologies. There are also ancillary features which either favor malignancy and either HCC in particular or not HCC in particular, and ancillary features favoring benignity. This is a very interesting meta-analysis. This was published in 2024, and the team showed that most Lirads AFs were independently associated with HCC, malignancy, or benignity, as intended when adjusting for major features. We all know these 2 tables. This is the 2018 edition. First of all, we have our diagnostic tree. You can see that there are 8 different categories. The LR1 to LR5 vary between definitely benign or definite HCC lesions. The LRM suggests lesions that are probably or definitely malignant, but not necessarily HCC. And last, the tumor in vein. So once we have concluded our reviewing of images and we have gathered all the imaging characteristics, then we use the diagnostic table to be able to assign our lesions to a specific category. So a few examples in each category. The Lirads 1 suggests the lesions that has imaging features which are diagnostic of a benign entity. On the top example, you can see that we have a lesion which is well-defined with high T2 signal intensity and does not really take up any contrast, so this is a simple cyst. On the bottom example, you can see a CT study, arterial and portal venous scan, and you can see that in the right posterior liver lobe, we have a lesion with peripheral nodular enhancement and centripetal filling on the portal venous phase in keeping with hemangioma. In the Lirads 2 category, we include lesions which are probably benign, so a typical appearing Lirads 1 observations in addition to regenerative or dysplastic nodules. Cirrhotic nodules, less than 20 millimeter in size without malignant features, as the example that we can see on these 2 MRI images. So high T1 lesion in the right posterior hepatic lobe, and T2, hypointensity. Approximately 16% of LR2 lesions are HCC, and of course 18% are malignant. In the Lirads 3 category, there is intermediate probability for HCC. So we have non-rim arterial phase hyperenhancement in lesions less than 20 millimeter with no additional major features, or arterial phase hypoenhancement or isoenhancement, and in sizes smaller than 20 millimeter with 1 or less additional major feature, or in lesions that are 20 millimeter or larger with no additional major features. At the example below, you can see that we have a lesion in the left hepatic lobe that enhances arterially, but there is no washout on the portal venous phase. Of all LR3 lesions, approximately 37% are HCC and 39% are malignant. And now the Lirads 4 category, which refers to lesions which are probably HCC. There is non-rim arterial phase hyperenhancement, and depending on the size, in less than 10 millimeter with one or more additional major feature, in size 10 to 19 millimeter with capsule and no other major features, or in lesions which are 20 millimeter or larger with no additional major features. And then arterial phase hypoenhancement or isoenhancement, and in sizes less than 20 millimeter with 2 or more additional major features, or in sizes equal to 20 millimeter or larger with one additional major feature. So if we go to the example on the right-hand side, we have a CT scan where we can see a sub-centimeter low-density lesion. 5 months later, this lesion has more than doubled its size, as you can see, so there is threshold growth. Of all LR4 lesions, 70% almost are HCC. And then we have the Lirads 5 category, which is definitely HCC lesions. We can see non-rim arterial phase hyperenhancement, and in lesions measuring 10 to 19 millimeter with non-peripheral washout and no other major features, or in lesions 10 to 19, again, millimeters with more than 50% or 50% increase in size in 6 months or less and no other major feature, or in lesions equal to 20 millimeter or larger with one or more additional major feature. Approximately 90% of these lesions are HCC and 98% are malignant. In the example below, you can see a large lesion which is hypervascular on the arterial phase scan and then washes out on the portal venous scan with a capsule. The tumor vein category refers to definite enhancing soft tissue in the vein, regardless of the presence of a parenchymal lesion. These are 100% malignant lesions. Most in patients at risk are associated to HCC, but they may include other lesions, which are always malignant. These patients, unfortunately, have poor prognosis due to the microvascular invasion. This is a case that I had a couple of years ago. On the CT scan, there was enhancing tissue within the portal vein with washout on the portal venous phase. This is the MRI that we did, where you can actually see again the enhancement, the washout on the portal venous phase, and the corresponding restricted diffusion. The Lirads M category suggests high probability or certainty of a malignant lesion that does not have HCC-specific features. We're talking mainly about targetoid masses, as this example that you can see below, which was a cholangiocarcinoma. And we're moving ahead with the Lirads CT and MRI tumor response assessment algorithm. As you can see, there are 2 different tables nowadays and after 2024. The first table refers to lesions which had locoregional therapies with non-radiation, and the second table, radiation locoregional therapies. The first table shows that we have 4 different categories: the non-evaluable, non-viable, equivocal, or viable. And it was decided to keep the equivocal category, and optionally one can use ancillary features like the restricted diffusion or the mild or moderate T2 hyperintensity to upgrade from an equivocal to a viable lesion. On the second table, you can see that the names of the categories differ a little bit. So we have the non-evaluable, the non-viable, the non-progressing, and the viable, again by the use of optional ancillary features, and the same ancillary features one can upgrade from the non-progressing to the viable category. In both tables you can see if we still feel uncertain, our report should reflect the lower certainty. Okay, I didn't break it. So this is a very recent example from our hospital. This patient has had a radiofrequency ablation 5 months ago. As you can see, there remains a lesion centrally in the liver that has mild T2 hyperintensity. On the T1 out-of-phase sequence, we can see low signal intensity. After IV contrast administration, we can see that there is a medial nodule of enhancement which restricts diffusion, so the decision was made to call this lesion still viable. But all of that have to have a clinical impact, and the main point here is to be able, by using this diagnostic algorithm, to have management suggestions. So each category has been associated with a specific management plan, and as you can see, the higher we go on the categories, then the multidisciplinary view of the cases and the patients are seen in order to be able to make the best possible management plan. And all of this, I'm sorry, I think that this is not working properly. Okay, and this is all connected to this framework from Barcelona for the diagnosis and staging of patients with HCC. Unfortunately, there remain gaps in the Lirads, and first of all, the use of pathology as a gold standard, as in itself it has imperfections. As we become better and better as radiologists in reporting and being able to make correct reports, we send less and less numbers of lesions for biopsy. So one might think that we might be sending atypical lesions, and maybe the pathology results can be skewed. So there is a shift nowadays towards focusing on more outcome-based studies rather than still be using pathology as the final stamp of approval. Lirads do not allow assessment of the transitional or hepatobiliary phase signal hyperintensity as a major feature. There remains moderate inter-reader agreement, and there is the challenge of intermodality agreement. Lirads only use 2 prognostic indicators, the TIV and LRM category, and there remains the challenge of the heterogeneity of LR3 and 4 lesions with very difficult management issues. So, our long-term plan, probably to create a system that provides a more precise prediction of the risks of HCC and malignancy in general, and some components of prognostication. Maybe 10 years down the line, we will be able to offer a more individualized management plan through a multidisciplinary always approach based on an AI model, estimating the probability of HCC, also the probability of a particular lesion responding to a particular therapy, and predicting the biological behavior and outcomes by using specific factors that have to do with the patient, the liver of the patient, and obviously the lesion itself. So thank you all for your attention.